and we're finishing it super strong with Dr. Jaime Wong. He's going to come and tell an important story. We were talking about patients and human perspectives, and we're also, of course, all about hearing about how technology impacts those patients. So Intuitive is a leader in the space, and I'm honored to have you come up and just share your view of the future of where this technology is going. So thank you for coming up.
That was great. Thank you very much. Thank you very much to MassDevice and to the organizers of Device Talks for inviting me to give the closing keynote at this year's conference. It's a privilege to be here, only a few miles away from Intuitive's headquarters, just down the street, to give our perspective on the trends and technologies which we think are shaping the future of healthcare, and more specifically, the future of surgical care. Just a little background on me. When I started off in school, I actually was in engineering, and then I realized that I wasn't smart enough to be an engineer, so I decided to go into medicine instead, and ultimately found my way into surgery, and I became a urologist and a Da Vinci robotic surgeon. But I feel very fortunate that I could find a new home at Intuitive, where I can combine my two passions of clinical care as well as innovation, with the main goal to try and improve patient outcomes. As part of my job, I have the honor of leading a team that includes human factors engineering as well as clinical development engineering. You got a little taste of Intuitive's perspective on human factors yesterday with Kevin Ten Brink, one of our leaders in the human factors group, giving our perspective on human-centered design. As well as if you snuck into the sister conference going on next door yesterday, Chunhua Zheng gave a presentation on clinical development engineering and how we use that process to identify clinical and user needs to help and improve our product. So I'd like to take this moment and acknowledge and congratulate MassDevice on their 10th anniversary of providing quality coverage of our industry, as well as this is the 7th version of this event here. And as I was preparing for this presentation, I started to think about what was going on in the world 10 years ago, way back when in 2009. And so although 2009 was the end of a decade, in many different ways, it was the beginning of an era. On January 20th, 2009, Barack Obama was sworn in as our 44th president, and this was the beginning of him serving two terms. And in fact, his inauguration was the highest attended event in DC in DC's history. The other thing, as many of you probably remember, in 2009 was actually the year that Kanye West came up on stage and interrupted Taylor Swift during her acceptance speech for Female Video of the Year. This is actually a controversy that continued on for a few years. And what I think is interesting is that if you look at the most recent list of the highest grossing music artists for 2019, number 1 was actually Taylor Swift, and number 2 was actually Kanye West. So maybe there's something going on that this was actually a real smart move on both their part in 2009. 2009, in many instances, was also the end of an era in many ways. So Sony decided that they were going to discontinue their floppy disks, as well as they were going to discontinue production of their Walkman. For those of you in the room who don't know what a Walkman is, it's sort of a precursor to an iPod. It was analog. We had cassettes as opposed to streaming. We had mixtapes as opposed to playlists. But both were certainly state-of-the-art technology at their time. And talking about state-of-the-art technology, the hottest wearable medtech device was actually Fitbit. And see, in this example, Fitbit Classic was actually more of a clip-on as opposed to a wrist-based type of wearable. And then Apple was number 3 in mobile phones, having just released their iPhone 4. And at Intuitive, the Da Vinci SI system was our latest surgical system. It was powered by our third major operating system and had advanced technologies like advanced vision, simulation, Firefly, and a dual console. And more importantly, by the end of 2009, over 500,000 patients had had a Da Vinci robotic-assisted surgery. And this was cumulative to date. Now, in 2019, our XI is our most highly integrated system. And we are currently on our major operating system number 4 with a much more integrated system, including technologies with cloud-based computational ability. And again, more importantly, over 6 million patients worldwide have experienced a Da Vinci robotic surgery, with over 1 million patients just in last year alone. So in fact, our systems enable a variety of approaches to a minimally invasive surgery. So on the left, again, you see our XI surgery, which is our multi-port robotic surgical platform. In the middle is our SP system, which stands for single port. So this is the example where it still has 4 robotic arms, but they all come through parallel and narrow together within a trocar that measures about 1 inch. And then after entering the body, the robotic arms open up with elbows that match the robotic wrists that many of you are familiar with from our multi-port system. And if the opportunity is right and you can avoid it, why cut it all? So you see on the right-hand side is our ION system, which is our endoluminal flexible robotic catheter platform, which enables surgeons and physicians to navigate through the airway to try and biopsy small lung nodules in the peripheral lung. So our mission is reflected in how we design our systems. Yes, great technology is very important, but it's just a tool. And ultimately, it's what people do with it which really matters. We focus on enabling people, surgeons, OR teams, healthcare leaders, and a host of other highly skilled professionals to heal without constraints. As you can imagine, I spend most of my day at work and a lot of my day outside of work thinking about how robotic-assisted surgery can help improve patient lives. So it may surprise you when I say that I didn't come here just to talk about robots. I actually came here to talk about people. When you think about it, surgery involves a sophisticated system of interactions among people, all centered around the care of another person. To get things right, you must have a deep understanding of and respect for the needs of each. You can't start designing a robot until you first consider people. Over the past 20 plus years, we've worked with our users to ensure that our solutions are actually solving their problems and not creating more of them. We've been able to incorporate in our solutions what we've learned from 4 generations of systems and over 6 million procedures worldwide. We decided to create a fully capable system that could address not just a variety of different types of procedures, but also a variety of different patient sizes as well. As you can imagine, there's great variability between a 5th percentile person and a 95th percentile person. And we decided to create a platform that can treat both ends of the spectrum as well as every patient in between. As we start discussing a variety of different types of med device and different types of technology, there's been a trend elsewhere to make things smaller. And so I often get asked, with other technologies getting smaller, how come your robots aren't getting smaller? And the reason is reflected by the use of the device. So if you actually look at the average person is actually getting bigger. They're not getting smaller. So we need to design our system in a way that can accommodate the variation in patient sizes. An interesting correlation is with cars like Mini Cooper. Similarly, one of the features of a Mini Cooper is that they try and design small cars. But they have one very important specification, and that is they are still a car, and people need to get into them to drive their car. So in fact, if we look at some of the older version of Minis versus the current version of Minis, they're actually getting a little bit bigger as well, because people are getting bigger. Similarly, there are constraints that must be considered when designing a surgical robot. So let's look at the height of our system, just as an example about why we chose the decisions we did. First, patients will lay on the OR table, and then in order to enter the body, we need to have a trocar. In this case, it's an abdominal or procedure in the abdomen. Then we need an instrument that the full length of it is outside the body and has to insert in the body. How long is that instrument going to be? Well, the instrument needs to be long enough to reach everywhere that you need to reach. So all these dimensions start to stack up. So that's great when the patient's laying flat on the table, but we also have to design for the environment that the device is going to be used in. And so oftentimes, surgeons will change the position of the patient on the table, in this case, a head-down position. And so we need to be able to ensure that we can design a system that can accommodate those conditions as well. And then, of course, you may want to be able to remove an instrument and reinsert a different instrument because different instruments are used for different tasks. Maybe you need to do cutting, maybe you need to do sewing. And then, of course, you probably want to fix all these instruments into something. In this case, we call that the boom. And then all of those dimensions actually stack up, ultimately results in the height of the surgical robot that we have. Although we first design around patients, we also spend a lot of time interacting with professionals across the continuum of care, from surgeons to OR teams to sterile processing departments, to understand the environment in which our systems are being used. We have a world-class human factors team who ensures we are performing human-centered design. And whether it's OR workflow or tray positions or peel packs, we're always looking for ways to streamline the process to try and make it a more efficient interactions across the care team. And of course, we design for the surgeon. Spending 8 to 10 hours a day for a 30-plus year surgical career can really take a toll on your body. Prior to becoming a Da Vinci robotic surgeon, I was actually a traditional laparoscopic surgeon, so I used straight stick laparoscopic instruments to perform minimally invasive surgery or keyhole surgery. I was early in my career, and I actually started to develop some ongoing neck pain and upper back pain because I was spending all day like this. And as you can imagine, I was pretty worried. I was early in my career, and I said, well, if this is how the pain is now, what will it be 20 years, 25 years down in history? Or even worse, after spending 15 years in education and training, will my surgical career be over before it even starts? Luckily, I gained access to a Da Vinci robotic system, which actually allowed me to transition my practice from traditional straight stick laparoscopy to robotic surgery. And fortunately for me, all of my neck discomfort and shoulder and upper back discomfort went away. I truly believe the ergonomic design of the Da Vinci system actually improved my career and hopefully will improve the length of other surgeons' careers as well. I often get asked if I think robots will ever completely replace surgeons. Our goal is to enhance a surgeon's capabilities through the intelligent use of smart instruments and systems, and to provide better precision, greater contextual awareness, or improved safety through features like Firefly, which can enable a surgeon to see vasculature and perfusion. These capabilities are enabled by the intelligent application of the most advanced technology there is, all in service to the surgeon and to the patient. I want to talk a little bit about smart instruments. So one of the areas where we invest heavily is through surgical stapling. So for many of you who aren't familiar with surgical stapling, it's sort of like your office stapler. What it does is there's a longer instrument. It lays down rows of staples, which is supposed to close one end of the anatomy. And then similarly, it puts down a row of staples on the other end of the instrument to close that anatomy, and then runs a blade through the two. So ultimately what happens, you have a piece of anatomy that's now separated, but closed on both ends. And so our Sureform stapler has SmartFire technology, which monitors tissue compression before and after firing, and can make automatic adjustments to optimize the staple line. This ensures that the staple line integrity is not lost and the anticipated length of transection is achieved. One time again, before I was a Da Vinci robotic surgeon, when I was a laparoscopic surgeon, I was performing a right-sided laparoscopic radical nephrectomy. So what that means is I was removing a kidney, a whole kidney for cancer. I was doing it laparoscopically with straight instruments, and I was doing it on the right side. Why that's relevant on the right side is that the renal vein, which is the blood vessel that drains the kidney, is actually very short and drains directly into another big blood vessel called the IVC, or inferior vena cava, which is the big blood vessel that drains all of the blood from the lower part of the body. And so one of the steps when you're performing a nephrectomy is to put a stapler along the renal vein to control the renal vein. So I put the stapler along the renal vein, and because it's short, I have to put it right against that IVC, that really big blood vessel. And so I fire the stapler. Unfortunately, none of the staples went across the vein, despite the fact the blade did go across the entire vein. And of course, I don't know this, and so I think everything's okay because everything's clamped. I unclamp the stapler, and effectively what I've just done is run a blade across the renal vein. So I unclamp it, I have this big gaping hole in the IVC, and it bled a lot quickly. You know, if you want to get a lot of people's attention in the OR very fast, that is certainly one way to do it. Luckily, after a lot of work and commotion and having to change my pants, I was able to get everything under control, and the patient ultimately did well. But I'd say every time after that, when I used a handheld laparoscopic stapler, which does not have that smart technology, I'd have a little bit of anxiety as I unclamped the stapler, unsure if it had worked or not. This is why I'm grateful for SmartFire type technology that can help tell me if the tissue cannot be compressed enough to staple and ensures that the staple line integrity is maintained. Having the right information that I need when I need it ensures that I get the outcome that I plan to have. Here's another example of getting the right information at the right time. On the left, you see our IRIS technology, or 3D segmented imaging technology, that's being used for a procedure called a partial nephrectomy. What a partial nephrectomy is actually, as opposed to removing the entire kidney, you actually just remove part of the kidney, usually because of a kidney tumor. On the right-hand side is the navigation software that goes along with our ION. That's our flexible endoluminal robotic catheter. As you can imagine, as you're trying to, as the interventionalist, the pulmonologist, is trying to navigate through almost like a series of mazes to go through the airway, this type of technology can help guide the way of where to go. In both examples, the user is being guided to see the end point. So you can imagine how something like IRIS on the left-hand side could be helpful for a surgeon pre-op to help them determine and plan what procedure they're going to perform. You know, by having this type of 3D segmented imaging, you can help determine, am I able to do a partial nephrectomy or remove just part of the kidney? Or is the kidney tumor too big that I have to remove the full kidney? Sometimes we go through the front, sometimes we go through the back, so this can help provide me with information. You could also imagine how it could be used intra-op or in the middle of the procedure to help identify, here's where the blood vessels are for the kidney, or here's where the tumor is for the kidney. So in all these instances, we're trying to make surgery easier on the surgeon and help reduce their cognitive load. You could also imagine how, again, something like IRIS could be helpful for patients during the preoperative consultation between the surgeon and the patient. As many of you have seen in the last speaker, we saw an example of an MRI, but an MRI or a CAT scan can be very difficult to understand as a patient. Sometimes it's difficult to understand for some physicians, and this makes it a lot easier to understand exactly what the anatomy is and what the tumor is. So we're also trying to make surgery and the experience better for patients as well. Algorithms are currently being used in research to identify features in a surgical video and be able to parse them into surgical steps. Here you see a bar with a variety of different colors, with each color of the bar corresponding to different steps of a surgery. What if we're able to use this sort of information real time to tell us when certain tasks occur? You could help the surgeon and the OR team by bringing up the information such as IRIS, which I showed a little while ago, at the right time and only the right time. You could send messages out to the family in the waiting room. If any of you have had family members who have undergone surgery, if you're sitting in the waiting room, it can be very stressful and anxiety-provoking, not knowing what's going on. So if we knew that we predicted that there's another 45 minutes left in the procedure. We could send out messages saying, hey, there's 45 minutes left in the procedure. At least you have some message of what's going on to give you some idea of expectations. Or you could also send, if you believe in trying, or you're in the business of trying to improve hospital operations, you'd be sending out messages to the pre-op team to say, again, we are an hour away from being done this case. We're 30 minutes away from being done this case, to let them know where you stand so they can start getting the next patient ready, so that way there's not wasted time in between cases. As you see, we're trying to make the experience better for everyone involved. Pivoting now towards another important topic. How else can we teach and learn the optimal way to approach surgery for the best outcome? Can we make skills acquisition a more efficient and standardized process? One way, we think, is through simulation. Virtual reality has been helpful for training and education. Our goal is to provide the most relevant and realistic simulation experience, which is why we continue to invest heavily in this area. On the left-hand side, you see our previous generation of simulation. And when I say previous generation, that's only about a year old. On the right-hand side, you see our most up-to-date simulation module. Advanced anatomic procedure simulation involves a time-intensive combination of artistry, technology, and finesse to create the look of realistic clinical anatomy for an incredibly lifelike experience. So although most people think of the efficiency and the effectiveness of a surgery to be the purview of a surgeon, it actually is important to have excellent OR care teams as well. And so just to give you an example of that, so I talked about a partial nephrectomy before, and so that's removing part of a kidney for a kidney tumor. So what's involved with that is the reason why we do a partial nephrectomy is because we try and leave some normal kidney tissue behind. And the reason for that is the more kidney tissue we leave behind, the less likelihood you run into trouble with your kidneys later on and potentially reduce your risk of dialysis. So we try, and the most important thing is to remove all of the tumor. You don't want to leave cancer behind, so you want to remove a certain amount, but you don't want to remove too little. You also don't want to remove too much, because then you're removing too much normal kidney tissue. And afterwards, you got to close it all up. What makes this sort of extra interesting is that the kidneys are very well vascularized. In fact, they receive about 20% of all your blood supply. So that means actually the kidneys take about 1 liter of blood every minute. So it's a lot of blood. So because of that, we actually put clamps on the blood vessel called the renal artery to the kidney while we're doing this to try and reduce some of the blood flow. So we're trying to do all of this, remove just the right amount of tumor, but not too much, close it all up. But we put a clamp on the renal artery, and as you can imagine, body parts don't like having no blood supply to it. In fact, they actually start to die if you leave it too long. So in fact, we try and do all of this just for an added extra little bit of stress, all of it out in about 25 minutes. And so you can imagine, I've actually had times where I didn't have my regular OR team with me, and I had a complex partial nephrectomy booked. I actually canceled that patient, actually put them to the next week, actually moved another patient in, all because I wasn't with my regular team. So we said, well, how can we help out all these other teams to make sure that we don't have this sort of thing? The patients deserve to have a good experience. They deserve to have the right team with them. So we said, well, the issue of why some OR teams aren't able to practice some of these maneuvers is because the Da Vinci system is being used to treat patients. So they have to do these practice maneuvers after hours, which is difficult. So we said, well, what have we learned from working with surgeons? We've learned that simulation seems to be helpful. Can we use simulation to help out our OR teams as well? And so this is a proof of concept where research performed by a group in Dallas, funded via Intuitive as well as the National Science Foundation, exploring how a simulator could be used for the OR team as well. And this is using commercially available hardware, software that they developed, and algorithms that they developed. But this now could then be held in, as opposed to having to wait for the system to not be used. They could do this anytime they want to. They could put this in the nurse's lounge, they could put this in a conference room, or they could put it in a closet, so that way they can be used when it's usable in the environment at the time that's relevant to them. So simulation is important to practice skills, but we also believe that meaningful insights can enhance education and training, regardless of where you are in your career. But in order to provide meaningful insights, we need to be able to quantify surgery. And so a lot of research has been done to try and quantify surgery. What this is here is from a review paper looking at a variety of different sort of scoring systems. But all of these approaches take resources to perform. You can either have one of a peer review you or a partner review you, but it's difficult, surgeons' time's expensive and difficult to get. You could have an expert review you, probably even more difficult. If you're a believer in the crowd, you could have someone who is not medically trained, but then it takes a lot of them to do that. So all of which actually requires some sort of resources. So we have smart systems and instruments, computer-enabled and sensed. So we thought to ourselves, well, how could we help move this forward? How could we help to make this more objective? And how could we help make this that these answers could be provided a lot quicker than they are right now? So in the next few slides, I'm going to talk about data. Clearly, data is important in the role of the future of healthcare, as well as in the future of surgery as well. A lot of value can be derived. The discussion is important, but transparency is needed. At Intuitive, we take data protection and data privacy very seriously. We do not sell data. We comply with all data privacy laws and regulations, and we take all necessary safeguards to protect that data. And we do engage with customers under appropriate, compliant data sharing agreements. So with our smart systems and instruments, the Da Vinci system enables the opportunity for deep contextual awareness by using these sensor measurements from the system, the endoscope, and the instruments. So what this demonstrates, on the upper left-hand corner, you see the endoscopic view, which we can use as ground truth and also so that you can see what else is going on. On the upper right-hand corner, you'll see the location of the tips of the two instruments in 3D space as well as time. And then we have the capability to capture a variety of different metrics. So in terms of location, we can, any other sort of kinematics, other system events, camera clutches, stapler fires, energy usage. And so just at the bottom of the screen is one example of that. This is the different wrist angulations of the two instruments. So we think this is particularly interesting. And academic research using ML for objective assessment of surgical skills shows some promise. So there's a urologist, so I'm a urologist, so I'm going to show you some urology things. There's a urologist down at USC who was one of the first ones to work with us in some of these projects. And so what he did in this research is he was doing a prostatectomy or prostate removal surgery for prostate cancer. And he divided up the users into what he called experts and novices, and those were divided by how many procedures they've done in the past. And so he looked at a variety of different steps of the surgery and said, just as I showed you in the last slide, we can look at the location of the instruments at different times. And so essentially this is sort of a summation of that, or a cloud of all the movements of the instruments. And what you can tell in the upper right-hand corner, it's actually really nice to see visually, is that the cloud of the movements is much tighter than the cloud of the movements of the novices. And so what we can infer from that is that the experts' movements are much more deliberate and much more exact. So I said, well, that's pretty interesting, at least graphically. That's an interesting thing to look at. And so he also looked at a variety of these different metrics, and these objective metrics that come from our system. I see some people squinting. The goal of this was not to read the slide. The goal of this is to show that there's a lot of different things that people looked at. And in fact, all the ones that are red are the ones that show statistically significant differences between the experts and the novices. And so the key point of that is that there does seem to be some what we call construct validity. Experts look different than novices from a variety of these objective metrics, or so-called Da Vinci metrics or DV metrics. So as a clinician, that's pretty interesting. Good, I'm glad we're starting to see these differences. That means we might be along the right path. But really what would drive me to make some decisions and really determine how relevant this is does it have an impact, or is there some sort of correlation with clinical outcomes? And the answer is, at least early research says that it looks like it could be. So again, he was looking at a prostatectomy. So one of the outcomes that's relevant for prostate cancer removal surgery is urinary control. Unfortunately, some patients have urinary leakage or urinary incontinence after they're having their prostate removed. And so just like any type of thing, if we did clinical research, what would you do? If I said, well, what are the risk factors to have this clinical outcome? Most surgeons would give me some patient characteristics, patient age, BMI, previous surgery, previous radiation. If it's cancer-related surgery, then maybe something related to disease state, stage, grade, things like that. So great. Let's take all of those clinical variables, let's put them in a model. Then also, let's take a look at these Da Vinci metrics, take all of those, let's put those in the model as well, and see what seems to be a predictor of, in this case, we chose urinary incontinence. And so what was interesting was that the top 10 variables that had they're impressed as well, actually, that's how impressive this is. The top 10 variables that predicted urinary incontinence were all Da Vinci metrics. I'm going to say that again in a slightly different way, just to sort of let that settle in. The top 10 metrics, none of the top 10 metrics that predict urinary incontinence would be any of the clinical factors which we would have based an entire model on prior to looking at these variables. So this is very interesting because now we're starting to look at things very differently, that maybe there are predictors that we didn't even know existed. And in fact, when you look at the top 5, 3 of them are related to a step called the anastomosis. So when you remove the prostate, your bladder and the water passage called the urethra are now disconnected, so you have to sew them back together. So the 3 of the top 5 are actually related to that step. And if you'd asked me before this, how important is that step for urinary incontinence, I would have said not that important unless you did a very aggressive sort of way of doing that. So again, this is causing us to think about things a little bit differently. And by having the ability to look at some of this data can actually potentially set us to consider different hypotheses than we would have before. And so so that's related to clinical outcomes. If you are passionate about hospital operations, so the other thing they did is we said, well, let's look at some other operations type variables. So most patients after having the prostate removed go home on either post-op day 1, so the next day, or post-op day 2, 2 days later. So they said, well, let's divide these into 2 different groups. Ones who go home on time and ones who go home late. And what they're able to identify that through some of these metrics, they're able to predict what the length of stay for these patients would be. And so we're not here yet, but you can imagine how in some version of the future of the world, that after a procedure, you would get some readout of some of the metrics that they did. There'd be some assessment of, okay, we saw some of the moves that you did, some of the kinematics, some of the other variables, and say, this patient, although you think they're going to go home on post-op day 3, they're actually going to go home, it's more likely they're going to go home on post-op day 2. And if that's the case, and if you're in a hospital like the type of ones that I work at, where we're usually at full capacity in terms of beds, then all of a sudden I now have an extra bed on post-op day 2 that I didn't have. And if that's the case, I can now do another operation 2 days from now. So now I can start calling a patient and say, I know we weren't planning to do your operation for a while. Can you come in 2 days from now? And I can take care of your operation because now I have increased capacity. As opposed to finding out on post-op day 2 when I discharge the patient, now I discharge them, but now unfortunately it's too late and I have an empty bed and I have an empty OR. So I think these things, we're still in the early stages of this, but I think this is pretty interesting and can be, there are a lot of different impact that it can have if we start evaluating different sort of concepts. And you could also imagine how this type of information can help decrease surgeon-to-surgeon variability in outcomes. And so on the left-hand side would be the surgeon of interest. So it either could be you, it could be a novice, it could be a trainee. On the right-hand side would be the exemplar video. So either could be your best one of doing it. If you're training residents, it could be you as the program director, or it could be your surgeon hero of choice. I like to, and then on the top hand, on the upper end of the screen, you can see some of those Da Vinci metrics, so you can assess it from a variety of different perspectives. So I kind of think of this almost like if you're a golfer assessing your golf swing. So if you just swing your club, you think, I have a pretty reasonably looking good golf swing. And then someone takes a video of you and you go, my golf swing is really not that nice. And then you compare it to Tiger Woods or whoever, and then you go, my swing is really terrible now that I can see them sort of side by side. And so this is ways that we can help to standardize technique. You could imagine if you are trying to train residents and you want to be able to provide them with feedback, this could be a way to do that. So at least you always, hey, try and train up to this exemplar. Or if you are the head of surgery for an IDN or integrated delivery network, and you want to make sure that the same high level of quality of care you get at the mothership is the same high level quality of care that you get in one of the other hospitals. That way you can ensure after a surgeon does a procedure somewhere else, you say, this is my best surgeon I want to compare everyone to, and try and ensure that everyone gets that level of quality across the board. So the hope is that this could be a tool that we could use to help decrease that variability and surgical performance and surgical outcomes. So bringing this all together, why is this all important? I believe that we all share a common goal. We want to improve patient outcomes. We'd also like to improve the experience of all people involved. And we'd like to achieve these goals all at an overall lower total cost of care. So how can we achieve all these aims? Well, you need a deep understanding of and respect for the human element of surgery. You need smart systems and instruments, computer-enabled and sense, and the cloud-based computational ability to provide meaningful insights. You need all three of these working together. If you take one out, you won't be able to unlock what's truly possible and allow physicians to heal without constraints. We call this intelligent surgery. And we're excited to be entering this next era and to realize surgery's full potential to improve patient outcomes, improve the experience of the patient, surgeon, and the care team, all at an overall lower total cost of care. Thank you.
Any questions from the audience? We have a few minutes. I know it's time to go, but anyone had some thoughts? Yes, back there.
Yeah, I had a question. So I come from a surgical robotics navigation background and mainly orthopedics. So we would register on bone, which would be very robust. Sometimes cartilage, which could be a little more difficult, but soft tissue registration is a non-starter for us. Can you describe like the more global registration, or are you guys getting a sub-millimeter type of soft tissue registration? Could you describe how that works in the back end a little bit?
So I'm going to disappoint you being a clinician. I'm not the one who's creating the model, so I'm sure you were hoping that I'd be able to give you some of the advantages to sort of push that forward, and I apologize that I'm not able to do that. What I'd say is that I think one of the big differences that you're highlighting is that bones are pretty rigid, cartilage reasonably rigid, and soft tissue moves a lot, particularly in the abdominal thoracic cavity, moves a lot, and is deformable, which causes a lot more sort of challenges.
So would you call it more of a global registration then? That's happening, so you kind of just know generally where you are in space, or is that really not happening?
So for ion technology, we actually have shape sensing technology, which can have thousands of measurements along the entire sensor. And so that's actually what provides us with that capability in order to help determine where that is, and so and feedback on itself.
Using your 10-year example from earlier, 10 years ago, it seemed like if you had a urologist at a hospital, like a key person on the surgical team that wanted a Da Vinci robot, they could go into the CEO's office of the hospital and say, I want one of these, it's great, we need to have it. And even though it was $1 million or $2 million price tag, it could get brought into the hospital. As the value-based care paradigm has progressed and shifted, has the strategy for Intuitive changed as far as how you get a system in a hospital that maybe was different from 10 years ago?
I think that's a great question with the change in healthcare dynamics. It actually suits Intuitive very well because it's value-based. And so one of the services that we provide are actually helping to identify some of the differences in outcomes. And that's why we believe that a lot of the improvements that we see with the Da Vinci system compared to, say, open surgery are actually even related to 30-day readmissions, 90-day readmissions, some of the impact of complications as well. And so when we demonstrate that, actually the great news with this change is that many of the purchasers, a lot of the healthcare executives are very facile in these sort of assessments as well. And so then we actually demonstrate how that's impacted their bottom line. And in fact, we've had, because of that, many different hospitals incorporate many robotic systems because they actually find that it's actually helpful for them from a financial perspective.
So, as a surgeon and a clinician, how do you think the system helps you select instruments? For example, you know the incident you talked about where you had bleeding because of non-functional stapler. What drove the selection of that stapler versus a vessel sealer, for example?
Yeah, so we always begin every problem with what's the user need we're trying to solve. And so this is why our human factors team, our user research team, market research team actually work very closely with our customers, and we have great relationships. That's the great advantage of being around for over 20 years and having great relationships with them. And so that's actually what helps us drive. We find out what is the problem that bothers you, and of course we also assess what are the ones that are driving negative patient outcomes, and that could be improved with improvements in technology to correct those.
One more question is, now that you're amassing more and more data and you're defining best practice and cleaner procedural algorithms, do you see us knocking on the door where, given a straightforward diagnosis, tumor, prostate, that you can essentially code into the robotic algorithm to remove this tumor using prior data capture? So essentially the robot may be driving like a self-driving car, driving on its own.
You know, I'd say, I get asked that question often as well. I'd say our goal is to enable our surgeons and provide them with the information that they need and provide the tools that they need. There's a lot of training that goes into becoming a surgeon, and I think we should take advantage of being a surgeon. I don't want to be replaced. I think that's, I'd lose a lot of friends. I think that was what my goal would be.
Yeah. Question on the training aspect of it. Do you see any value in using the data to drive the ability to get like haptic feedback or force resistance in the training process to help reduce that excessive actuator motion?
You know, I think that haptics is an interesting topic. You know, and so and different people have explored it for different times. And I think where we are trying to determine is what are the different outcomes that could be sort of meaningful for that type of one, and what would be the right group and or types of procedures that would actually provide meaningful, you know, to have meaningful improvements in outcomes at an appropriate cost.
Thank you so much for the talk and for taking the question. I'd like to thank the laptop for processing all those videos properly in the presentation. I was holding my breath there, but they all worked out so well. And thank you all for being part of a great 2 days. I've learned a ton. I'm really excited about the opportunity here at Device Talks. Once again, please reach out to me with any ideas as to how to make these programs more vital to you. And really hope we'll see you in Minneapolis in March. And we'll be back here actually on the West Coast in June. So it's going to be a larger program at the San Jose Convention Center. So stay tuned for that information. So thank you again for coming out.